All right, so patient is alert and oriented times 4, appears healthy and well, dressed appropriately, and cranial nerves 1 through 3 I previously performed in the HEENT assessment. So cranial nerve 5, trigeminal, doing sensory. So just having the patient tell us if they can feel in the forehead, cheeks, and then the lower part of the jaw sensation. And then for cranial nerve 7 or facial nerve, just have them do facial expressions. So smile, eyebrows up, and puff the cheeks out. And then don't need to perform taste for cranial nerve 7. And then cranial nerves 8 through 12 I performed previously as well. So going to primary sensory function, you're going to have the patient close their eyes, inspecting upper and lower extremities, and then doing sensation in several spots on upper and lower extremities, of course bilaterally, and having them tell you if they feel that with light touch. And then superficial pains, having them tell you apply dull pain, so go ahead and keep your eyes closed and tell me if it's dull. Or sharp. Dull. And then sharp. Okay, testing that in several spots on the upper and lower extremities bilaterally, and then doing vibratory responses. So this is my tuning fork, going along bony prominences on the upper and lower extremities, clavicle, shoulder, and then olecranon process at the elbow, going on the radial side, bony prominence, and then of course at the knee, patella, and then at the ankle, in the heel, and then the medial malleolus. And checking then for peripheral neuropathy with a monofilament. So you go to the bottom of the foot and you go in several different spots on the bottom of the foot with a monofilament, and you press it in until you see it start to bend, and you hold that for 1.5 seconds. And that is just checking to see staging for peripheral neuropathy with patients with diabetes mellitus. And then the Sterognis test, trying to identify an object with their eyes closed. You hand them, this is just a pen. And then the 2-point discrimination test. So this would be my paper clip, and applying pressure with 2 points, and then going to a different spot and doing it with 1 point, and having the patient state if it's 1 or 2 points, just testing for sensation. And then the graphesthesia test, putting their palm out and drawing a letter in their hand and having them identify which letter you drew. So for superficial reflexes on the abdomen, you would have the patient lay supine, you don't have to. And testing for the upper quadrants of the abdomen, you stroke whatever you have. For sensation, testing an upward motion away from the umbilicus, and then the lower quadrants you stroke downward away from the umbilicus. And then cremasteric, you stroke the inner thigh to check for sensation, and then of course Babinski reflux, stroking the palmar side of the foot to check and see if it's a normal reaction. And then checking deep tendon reflexes. So bicep, you would have your tool for checking reflexes, and you put your thumb there, checking for bicep, and then hitting on your thumb, and then brachioradialis, moving down to the lower forearm, and hitting with the thumb, doing this bilaterally, of course, and then triceps on the posterior side of the arm, and then your patella and Achilles on the posterior side, and then checking for ankylosing, which would be flexion or extension involuntarily. And then for checking knee strength, you can do deep knee bends bilaterally, checking to see with resistance. And then checking for coordination, you can have them stand up and do heel to toe walking, one foot in front of the other, can't really see, but doing heel to toe walking, and then doing on toes and then on the heels, watching gait and seeing if they're unbalanced, and then hop on one foot in place. There you go, checking both sides bilaterally, and then heel to shin. Yep. No, just heel to shin while you're heel to shin while you're standing up. Check to see if they lose their balance, and then checking pronation and supination, and then for the Romberg test, you have them stand up again, close their eyes for 20 to 30 seconds, and see if they're swaying, if there's any loss of balance. And then checking meningeal signs, you have the patient go in supine position, and then using your hands behind their head and neck, and then flexing it towards their sternum, looking to see if there's any involuntary flexion at the hip or the knee, which would be a positive sign of any meningeal involvement. And then that'd be the Brudzinski sign. And then the Koenig sign, you flex the patient's knee and hip and ask them if they're having any lower back pain.